And it is a pleasure to leave the floor to Professor Attila Szabó, Professor and Vice Rector for Clinical Affairs and President of the Clinical Center of Semmelweis University. Please, you have the floor.
Thank you very much, President Sasso, Rector Borhi, Rector Merkeli, President Sasso, dear colleagues, ladies and gentlemen. On behalf of the 250 years old Semmelweis University, I'm a capacity as the Vice Rector for Clinical Affairs. It is my privilege to welcome you on the occasion of COVID-19 Biomedical, Social and Legal Aspects webinar organized by UNICA, Eötvös Loránd University and Semmelweis University. It's a great honor and pleasure for me to greet many experts on this field. Thank you very much that you accepted our invitation. I'd like to inform you that unfortunately, Thomas Zima, Rector of Charles University, is unable to attend the webinar due to an emergency meeting related to COVID in Prague. This is showing us also how important is COVID-19 in our everyday life. So this morning we will discuss about the biomedical aspects of COVID-19 pandemic. Our first speaker is Professor Veronika Müller. She's head of the Department of Pulmonology at Semmelweis University, and since the beginning of COVID-19 pandemic in Hungary, she is the head of the COVID department at Semmelweis University. She will speak about clinical management of COVID-19 patients at Semmelweis University. So, Professor Müller, the floor is yours.
Dear colleagues, dear organizers, thank you so much for giving me the opportunity to share with you some of the data of the Semmelweis University clinical management of the patients. I would like to share the screen. So as mentioned formerly, I am head of the Department of the Pulmonology, so I can only share with you some aspects for patient care in a pulmonary ward. I will not touch emergency department issues or intensive care issues. So first of all, you saw the numbers that we have a second wave going on, and the first case in Hungary was reported on the 4th of March. The first casualty occurred in the 14th of March, and the second wave, we have it going on from September. My topic will mainly focus on the first wave as we have data analyzed for this period only. So what about the COVID-19 and the lungs? You know that the virus is called SARS-CoV-2. The infection results in the disease, which is called coronavirus disease. And the clinical manifestations are mainly represented in 80% of the population with no symptoms or mild upper airway infections, and roughly 20% of the patients develop pneumonia. From all infected, about 5% have severe pneumonia, which is related to severe acute respiratory syndrome, which is mainly treated in the intensive care units. The publications still now focus mainly on severe cases needing hospitalization, and data on patient management or outcomes from the population are scarce. So it was really a big issue to see data from Hungary, as Professor Merkeli mentioned in the previous lecture. So what is happening in the lung when you have an infection with this new virus? Normally, you see an alveolar structure on the left side, which is consisting of mainly pneumocytes and alveolar macrophages. And when you have an infection, the virus is getting into these cells, and cells are producing a lot of chemoattractants like TNF-alpha or interleukin-6. And due to these chemoattractants, there is a loss of the normal structure of the lung alveoli, and then the lung is not able to perform their main goal. It means taking up oxygen and removing CO2. Just to show you how you can see these two different sets in a CT scan, chest X-ray is not sensitive enough, So in the beginning, you only see some mild ground glass opalescences as in the upper picture. And then if you have a big disease involving a lot of lung tissue, then you have severe lung damage. So from the Semmelweis University, the first case was in March, and in our department, we had our first case on the 11th of March. And at that time, we had a central patient care in our country in Budapest. So we transferred this single patient to another department. However, already at that time point, we had a good developed escalation plan for the Semmelweis University, how to deal with potential infections. So we had checkpoints at entry for personnel, strict regulation for hand hygiene, and use of personal protective equipment. Central patient entry was introduced via the emergency department, and we had a central intermediate department from 15th of March in the Central University building for internal surgical cases. And as the situation evolved, we had to develop our own COVID department, and it started on the 9th of April. It was a multidisciplinary department, and I want to share with you some of these data. So we had a very well conducted management plan and handbook available for everyone. And then we started to work at this new department. Mostly we had nurses from all departments coming together, working in 12-hour shifts, 6 nurses per shift, 1 physiotherapist. We had physicians also for 12-hour shifts, from mainly per month, 3 to 5 specialists and 8 residents per month. So you see they came from all over the disciplines in our university. So it was really a big teamwork. I want to share with you some of the pictures of the 3 first teams, mainly involving the medical doctors. Definitely, as a lot of people came together, it is always a very important place for continuous education, also for the nursing staff and for the doctors. And there is always a big teamwork going on. So we are learning and working together. I want to share you some pictures of the department. You see all personnel is well equipped and in this personal protective equipment. It was a big challenge to work in this special setup. So when the patients came to our department at the admission, we were very much interested in a broad microbial sampling. So hemoculture, if patients were having other symptoms, Streptococcus and Legionella were tested for antigen, and we had influenza still in the March-April time. So influenza and respiratory syncytial virus, PCR, if sputum available, sputum culture, urine culture were performed. For all patients, we used lung low-dose CT just to see early changes and see the evaluation and evolution of the disease. And we were checking regularly the clinical parameters twice per shift using the new score. Regular consultations were with our infectology specialist colleagues. So I want to share you one of our patient cases where you see a very early changes infecting a lot of parts of the lung. So there were in the upper, middle, and the lower parts of the lung, a lot of specific changes for this new virus disease. So our first experiences from April to July, we had 74 cases, including 70 patients. 4 cases had second hospitalization due to recidived PCR positivity. We also had some observation for postoperative patients. During this period, we have 5 deaths, all above the age of 70 years, with a mean age of 82.5 years. All had really severe comorbidities. I just want to share you the daily number of the treated patients at the Central COVID department. You see that even in this short period, we had 2 smaller waves for patient care. Very important part was to deal with possible treatments. We know that in the beginning we had some antiviral or some drugs with potential antiviral properties. So hydroxychloroquine and lopinavir, ritonavir was not really quite oftenly used, but favipiravir, and in a very nice investigator-initiated study concept, convalescent plasma, was introduced, and it's always was done after an infectology consultation and with consultation of our clinical pharmacists for comorbidities and drug interactions. So some summary of the data, we had little bit more men than women in our care, mean age 65 years. The PCR positivity lasted in average for 10 days and the hospitalization was roughly 2 weeks. Severe comorbidities were present in 90% of our patients, and COVID pneumonia was seen with the CT in 65% of the cases. Other infections were also very common. Patient needed hospitalization, so 1/3 needed also some other care. About the specific therapies, we had not too many patients, so the data are still under analysis and we are waiting for the new data from this second wave. So favipiravir was mostly used and convalescent plasma. We also used azithromycin therapy and some other antimicrobials. About the outcome, we had very good results during this first wave. 62% were cured, 31% were transferred to other units for further treatment or some nursing care, and only 5 patients, 7% died. On the right side graph, I'm showing you some data according to the therapies used and the hospital stay. Actually, the data are not really nice yet because the numbers are very, very low. So we are evaluating the second wave data to have better insight about the treatment possibilities. And just to share you a case, it was also a big challenge, and we introduced COVID-19 in our pulmonary curriculum, especially using a lot of case reports. So it's also a teaching activity which we can improve, and the students are they really like these concepts. So it is a 61-year-old male patient with a kidney transplantation admitted just in the beginning of September with 7 days of cough, dyspnea, and low-grade fever. Just showing you the CT scan, you see we have a huge involvement of the lungs, a consolidation with ground glass opalescences involving 50 to 75% of the lung parenchyma. He was just treated on a normal ward, did not need intubation or intensive care unit care. We used favipiravir, low-dose methylprednisolone, and convalescent plasma for treatment. Immunosuppression due to his transplant was continued, another one discontinued, and some additive treatment was also used. And I want to share with you the very nice data on day 6, the CT scan. I think you can see it was a significant improvement and reduction of the pneumonia. However, PCR was still positive, but he was really in a very good shape, so he decided to go home for home quarantine. I would like to thank again the organizers for giving me the opportunity and just sharing with you some of the nice data we had in the first wave, and we hope that we will deal with it similarly in the second wave. And I would like to thank all my co-workers who worked with me in the COVID department. Thank you so much for your attention.
Thank you very much, Professor Müller. Just a little comment that this data was mainly from the first wave in Hungary, and during the second wave we enlarged the COVID department. We have unfortunately much more patients now, and hopefully we can use the first wave experience